Good evening, everyone, and welcome to this Spirit of the Heart Community Leaders Forum in Baltimore City, hosted by the Association of Black Cardiologists, Incorporated, and by the Baltimore City Medical Society Foundation. I'm Anthony McCarthy. I have been the past editor of the Afro-American newspaper, and I'm the host of Two-Way Talk on WEAA 88.9 FM radio here in Baltimore. I've also had the pleasure of assisting 3 mayors of Baltimore in communicating with our communities. Tonight, I'm here to help bring awareness about heart disease, high blood pressure, diabetes, and other cardiovascular risk factors to our communities so that we can take action to address the deaths that our community suffers each year from these preventable conditions. We are approaching 2 years of dealing with the coronavirus and the devastation it has had on our community. Have had over 10,800 people die from COVID-19 in Maryland alone, and over 1,300 individuals die from COVID-19 here in Baltimore City. But while it is important to recognize the risk of COVID and make sure to get vaccinated, we must still pay attention to the number one killing of individuals in Baltimore, and that is heart disease. Before we begin our program, we have an opening prayer by Reverend Brown. Reverend Brown, would you please lead us in prayer?
Yes, thank you. Grant, O God, that your holy and life-giving spirit may move every human heart, especially the hearts of our communities, that barriers which divide us may crumble, suspicions disappear, and hatred cease, that our divisions being healed, we may live in justice and find peace of understanding, peace of mind, and peace of heart, so that we can be the resources that are needed in the community by using our hands and our feet and our voice to make a difference, to help heal and to help prevent the kinds of heart disease that plagues many individuals. And this evening, through the Association of Black Cardiologists, saving the hearts and minds of a diverse America through the spirit of the heart of Baltimore. We pray this in your name, and through your help, O Lord, we move forward. Amen.
Thank you, Reverend Brown. So I'd like to thank you for joining this community forum and wellness symposium. In addition, I also want to extend a special thank you to the symposium, planning committee, volunteers, and our sponsors. Programs such as this would not be successful without the continued support of our partners. Before we begin this great program, we will have a welcome from ABC's Dr. Debra Lucy, an advanced heart failure cardiologist at Johns Hopkins University, followed by a message from Governor Larry Hogan and Mayor Brandon Scott.
Good evening. On behalf of the Association of Black Cardiologists, in partnership with the Baltimore City Medical Society Foundation, we are ecstatic to welcome you to the Spirit of the Heart Community Leaders Forum for our charmed Baltimore City. I am Dr. Debra Lucy, a heart failure cardiologist at the Johns Hopkins University School of Medicine and current member of the board of directors of the ABC. This is a particularly special evening for us, as I hope it is for you, because Baltimore is where ABC started its community health initiatives over 45 years ago, when Dr. Elijah Saunders, the first African-American cardiologist in the state of Maryland, began using churches and barbershops as hypertension control centers. Ever since, the Spirit of the Heart continues to live on as ABC's signature program, actively empowering and educating community members, faith-based and civic leaders, health advocates, and health providers in addressing local barriers to cardiovascular health that put our communities at risk. We, as members of the ABC, pride ourselves in championing change in cardiovascular health and health equity locally, nationally, and abroad. Over these past 45 years, ABC has led the change and the charge in communities by implementing action, addressing policy, directly talking with legislators, and building a pipeline of cardiologists, scientists, and allied health professionals to raise awareness of the devastating impact of heart disease and disparate outcomes in communities of color. Cardiovascular disease remains the #1 cause of death in the United States. We have to change the narrative of worse outcomes, higher proportion of deaths and hospitalizations, and poor quality of life for Black and Brown people living with heart disease. We are emboldened to stop heart disease in its tracks when we strive to do this by providing you, our communities, with knowledge regarding heart disease prevention, best practices in management, access to care and life-saving therapies, and worthwhile lifestyle changes that are essential for wellness. We hope this event increases your awareness of the importance of cardiovascular disease prevention and highlights a path to a healthier Baltimore for all of us. Share the information you received tonight with your family, your neighbor, your congregation, your sorority, your fraternity, your colleagues, and even your doctor. We hold true to the adage that children should know their grandparents and be great-grandparents too. Prevention and advocacy for the highest quality cardiovascular care right here in our city is the only path forward. Baltimore, we are truly delighted to be here, and thank you for your participation.
Good evening. It's an honor to join you virtually for the Association of Black Cardiologists Spirit of the Heart Leaders Forum. The COVID-19 pandemic has impacted all of us in a variety of ways, but it has sharply highlighted the great disparities in health outcomes that continue to burden minority communities, especially those who suffer from comorbidities and cardiovascular diseases. Today's program will bring together health professionals and leaders to come up with solutions that can be used to address these disparities and close the gap on health outcomes for patients with heart diseases. All of us have a role to play in this very important work, and I want to thank you, our healthcare heroes, for your leadership. I look forward to working with all of you to make progress and continue to fight for a healthier and more equitable Maryland. Thank you.
This is Mayor Brandon Scott, and on behalf of the citizens of Baltimore, I would like to welcome you to our great city and the 2021 Spirit of the Heart Leaders Forum for Baltimore. Tonight, you will discuss how we can address cardiovascular risk factors for our citizens in Baltimore, and as we emerge from the coronavirus pandemic, we want to recognize that health disparities in heart disease were a problem for our communities well before COVID-19. If we don't take the steps to mitigate the circumstances that created these disparities, then the health disparities in heart disease will continue to burden our minority communities. The good news is that there are steps that we can take to begin to address the gaps in care. Cardiovascular disease is a leading cause of death for all Americans, but the burden is particularly high for Black people. High rates of hypertension, diabetes, obesity, and other risk factors to heart health lead to greater disease burden in Baltimore. Since these complications are not identified and treated in Black community members at an earlier stage, it leads to higher rates of premature death for our residents. During the next hour, you will hear from our speakers on the heavy burden of heart disease in Baltimore and how we can use new tools and strategies to begin to reduce these burdens and tackle health disparities together. I encourage you to participate in the program, discuss and think about how we can all contribute to make Baltimore a healthier city. Thank you.
We'd like to thank Dr. Lucy, Governor Hogan, and Mayor Scott with those incredible messages of welcome. Addressing heart disease and reducing disparities is important to all of us in Maryland. If we are to make the changes necessary to reduce deaths from heart disease, then we definitely need to work together on solutions that help solve these problems. But how big is the problem of cardiovascular disease in Baltimore City? Our next speaker, Dr. Kendra Mcdowell, will provide us with the current state of health in Baltimore City. Dr. McDowell joined the Baltimore City Health Department as Chief Medical Officer in October 2020. Dr. McDowell is a board-certified pediatrician and CDC-trained medical epidemiologist. Prior to joining the health department, she completed the CDC's Epidemic Intelligence Service Fellowship, where she deployed and provided technical assistance for multiple domestic and international investigations. Dr. McDowell received her BA in Biology and Religion from Swarthmore College. She earned her medical degree from the Mount Sinai School of Medicine and Master of Public Health from the Mailman School of Public Health, Columbia University. Dr. McDowell completed pediatric residency at the University of Maryland Children's Hospital and is a fellow of the American Academy of Pediatrics. Dr. Kendra Mcdowell.
Good evening, everyone. Thank you so much to the Association of Black Cardiologists and the Baltimore City Medical Society Foundation for the invitation to come and speak today at the Spirit of the Heart. As mentioned, my name is Kendra Mcdowell. I'm the Chief Medical Officer of the Baltimore City Health Department. I will be talking today about cardiovascular disease and associated risk factors such as diabetes. In addition, we will be focused on the social determinants of health that lead to disparate health outcomes across the city. I do want to highlight in particular what was mentioned about COVID pandemic and encourage everyone on the line to get vaccinated if you have yet to get vaccinated, and also to encourage your family and friends to get vaccinated as well. We know that cardiovascular disease, diabetes, and other underlying medical conditions put our community at increased risk of COVID-19 disease, hospitalization, and death, and the vaccine protects against this. Please get vaccinated. Next slide. I can do that. So first, I do want to ground this conversation in talking about the mission of the Baltimore City Health Department. Baltimore City Health Department, our mission is to protect health, eliminate disparities, and enhance the well-being of everyone in our community through education, coordination, advocacy, and direct service delivery. So going into our city's demographics, Baltimore City has a little bit less than 600,000 residents and is predominantly African American, making up about 60%, 63% of the population. 1 in 10 residents do speak a language other than English, and about 8% of the population was born outside of the US. There is a high prevalence of conditions such as diabetes, obesity, that are risk factors for heart disease. Our population, about 20%, are our older adults, and we know heart disease increases with age. Social determinants and structural racism have led to disparate health outcomes across our city. 1 in 5 residents live in poverty, and about 6% of residents have no health insurance. Of note, this data is pre-pandemic, and we are still seeing the effects of the pandemic on individuals' socioeconomic status and also health insurance status and access to healthcare. In addition, about 2,000 residents experience homelessness on a given night. Racial residential segregation, which is historical in Baltimore City and across the US, has resulted in these disparate outcomes and also disparate and unequal access to certain resources that can lead to improved health. So diving a little bit deeper into cardiovascular disease prevalence. In Baltimore City, we have an overall prevalence of cardiovascular disease at 9%. We can see, looking at our Black community versus the white community in Baltimore City, that the cardiovascular disease prevalence is higher in our Black community, in both women and men. Overall, it is 10.6% and approximately 11.7% in African American men. Cardiovascular disease is the leading cause of death in Baltimore City, like it is nationally. And about 24.4% of total deaths, so almost a quarter of total deaths in the city, are due to cardiovascular disease. This is followed by all kinds of cancer, lung cancer, colorectal cancer, breast cancer, prostate cancer, and also stroke. In regards to mortality, Baltimore City's death rate exceeds, for several important causes, exceeds statewide rates. As you can see in this chart, the Maryland rates of diseases of the heart, so heart disease, is in orange. And we can see that the rate of heart disease in Baltimore City exceeds that in heart disease, cerebral vascular disease, so stroke, for example, and also diabetes, a risk factor for cardiovascular disease. We know that life expectancy as well in the city varies by neighborhood. There is a more than 2-decade difference, so 21.5 years in life expectancy between community statistical areas or neighborhoods in Baltimore City. When we look at downtown Seton Hill, the life expectancy is 63.2 years compared to a life expectancy at 84.7 years for cross-country Cheswold. This difference in life expectancy based upon geography really highlights that socioeconomic position impacts our health outcomes. Socioeconomic position, and that is marked by income, wealth, also education as well. One's social connections and social networks, the environment in which someone lives, and also physical insecurity such as crime and violence. This is associated with higher cardiovascular disease incidence and also death from heart disease. In addition, it is associated with a higher prevalence of heart disease risk factors such as diabetes. Diabetes prevalence in our city is higher among women and also Black residents. It also increases with age. As we can see in the middle bar chart in the orange bars, the city prevalence for diabetes, so overall, when we look across the city, 11.8% of individuals have a diagnosis of diabetes. For the African American community, overall, 13.7% of our community have a diagnosis of diabetes. We can also see at the chart, the bar graph on the right-hand side in blue, that with increasing age, we see an increased prevalence of diabetes diagnosis. Baltimore City Health Department has a demonstration project known as Accountable Health Communities. This is a 5-year project funded through CMS, Center for Medicare and Medicaid, and it functions to connect individuals that are high utilizers of healthcare systems, such as the emergency department, and also are on Medicare and Medicaid and have an identified social need to resources that can support them and also fill the gaps on those social needs. Since 2018 to 2021, we have learned from approximately 3,000 Baltimore City residents the top social needs for our city. Financial strain. Out of these 3,000 residents, 81% indicate that financial strain is a major social need. Access to food, mental health, and transportation are the top four. Since 2018, financial strain has been the top social need for residents that take part in the Accountable Health Communities Demonstration Project. We see that financial difficulties within this group have been linked with the higher prevalence of mental health issues and also tobacco use. Tobacco use and mental health issues caused by stress and strain have been linked to heart disease. Smoking is a risk factor for heart disease. And we see this connection between financial stability, our socioeconomic position, and risk factors that can lead to the development of heart disease among African American people. We also see that a lower percentage of individuals with low income compared to individuals with high income have positive health-related outcomes. I know this graph is a little busy, but if we look in particular at current smoker, exercise, our individuals that have a mobility disability indicate that they have depression. We see that there's a higher percentage of individuals that have low economics that are reporting having a depressive disorder, smoking, not exercising outside, or having a mobility disability. This all leads back to the upstream factors of socioeconomic position. In conclusion, I would like to highlight that in our city, cardiovascular disease or heart disease is the leading cause of death, and that there are racial disparities in the burden of heart disease across the city, with Black residents having the highest disease prevalence. Socioeconomic position and all of the factors that interplay with it, such as your lived environment, your neighborhoods, such as your actual wealth and financial resources, are linked to mortality and your risk of developing cardiovascular disease. Interventions such as the Accountable Health Communities focus on upstream factors are needed to close and hopefully ameliorate disparate health outcomes that we are seeing across our city in relationship to chronic disease such as heart disease and diabetes. Thank you. Thank you for the opportunity to present.
Thank you, Dr. McDowell. That was extremely informative about the burden of heart disease in our community. Action is needed to reverse those trends and improve the health of our community. There are steps that we can take. Next, we will hear about some of the steps that we can take from Dr. Marlene Williams. Dr. Williams obtained her undergraduate degree from McGill University in Montreal, Quebec, Canada, and her medical degree from Columbia University in New York. She completed her medical residency training at Johns Hopkins Hospital. Her cardiology fellowship training was completed at Mount Sinai Hospital in New York and Johns Hopkins Hospital in Baltimore, Maryland. She's an associate professor of medicine in the Division of Cardiology and is the clinical director of cardiology at Johns Hopkins Bayview Medical Center. She participates in research, teaching, and clinical care. Welcome.
Thank you so much, Mr. McCarthy. And as a member of the board of directors on the Association of Black Cardiologists, I wish you all a good evening. Along with my colleague, Dr. Camillus Izugu, we'd like to discuss the topic of promoting health equity in telemedicine and telehealth. And this translates to providing care everywhere for everyone. All of us on this program tonight are keenly aware that we remain in the midst of a worldwide pandemic, which has had devastating effects and consequences, particularly in the African American community. When this started in 2020, the medical community came to the realization that because of and in spite of the pandemic, the need for medical care continued. We had to ramp up in some cases and in other cases pivot quickly how we provided the care to the broader community. And as we all know, we had to maintain our distances while providing that care. Hence, a greater reliance on remote patient monitoring and virtual visits. So what is remote patient monitoring? Remote patient monitoring is a patient and provider partnership where the patient collects daily health data in the form of temperature, blood pressure, weight, blood sugar, medications taken, and even oxygen levels. And they measure this using provided equipment. Sometimes not all of this information is needed, and then they send this information to their medical provider, either via telephone, smartphone, computer, or even cellular devices that upload this information directly to your provider. You're not sitting in front of a medical provider, but you're communicating this information to the provider. The provider receives this information and interprets it and then communicates back to the patient, not on a daily basis, but with a frequency that helps to keep this person or yourself feeling well when you're in your own home. And so remote patient monitoring is not a telemedicine visit. It's not a regular office patient visit. It's not easy because it requires medical provider and patient engagement. But it's not only for a few, those who are educated and rich and privileged and have major support. It's really for everyone. However, it's not currently accessible to all, particularly based on sometimes on insurance. So insurance type and copay requirements can sometimes exclude certain people from participating in remote patient monitoring. In fact, this past year, it was exposed that identical insurance in Baltimore County residents had the copay covered. However, Baltimore City residents did not, and they were billed for the copay for remote patient monitoring. My colleague, Dr. Izegu, was instrumental, along with others in the Baltimore City Medical Society and MedChi, in pursuing a resolution to make remote patient monitoring available for all, regardless of insurance and location. Therefore, basically getting rid of this copay. They were successful in reducing major inequity in remote patient monitoring, at least for now. So why use remote patient monitoring? Remote patient monitoring has been shown to prevent complication, reduce hospitalizations, reduce emergency room visits, and reduce healthcare costs. And all of these together combined impacts overall health. I want to show you an example of a real person that was monitored using remote patient monitoring. And what I'm showing you here, you don't need to be a physician, a nurse, or even within the healthcare field to appreciate what this remote patient monitoring can have. So we see these blue dots on top of here. These blue dots, it seems to be running in a straight line. This 86-year-old woman was measuring her blood pressure and reporting it on a daily basis. And we see that it's pretty much about the same over a period when she had to, maintain distances from any large groups. And this was in 2020 going on to 2021. And this was her top number was her blood pressure. The bottom number was also the bottom number of her blood pressure. And that seemed to be about the stable. These orange dots show us what her heart rate was and her pulse, also known as that. But what happened is that she was sending in this information on a daily basis. But interestingly, this number down here, her pulse was significantly different. So it was no longer up here, but down here. So it was lower. What she did was, because she was sending in this information daily to her medical provider noticed a change and in fact contacted her. She said, well, she wasn't feeling so well. She felt maybe a little dizzy. They were able to arrange for her adult daughter to stay with her while they did testing, and she was sent for certain testing. And this testing came back around here, and they realized that her heart rate was very low and she had a life-threatening condition. Immediately, her cardiologist then summoned her and brought her into the hospital to have a life-saving pacemaker placed. And then afterwards, she was discharged home and continued to enter this information. So we can see where remote patient monitoring literally saved her life. So it's certainly, a remote patient monitoring comes with certain barriers. Some people are very concerned and have a lot of fear about what knowledge they're going to gain from remote patient monitoring. And we can't stick our heads in the sand. This is really something that's going to help us provide better care and also improve our own overall well-being. There are issues with insurance copay, as I just described to you. And there's also issues with technology, uploading this information and actually using special equipment that's necessary to communicate with your healthcare provider. And then finally, there is a patient factor compliance. So although it might be tedious, getting this information helps you to feel well in your own home and communicate with your medical provider. So how else can you care for yourself besides remote patient monitoring? There are video visits with medical provider and telephone visits with medical providers that actually is what we call telemedicine. So virtual care uses technology like telephone or video to help you connect with or talk with your healthcare provider in real time when you're not in the same place. And these are some examples of how you can interact using virtual visits with your provider. But many have also looked at barriers to telemedicine and video visits. And in fact, there are formal groups that have studied this and published papers on this. Barriers generally fall within two major categories. One is tools. Do you have the tools necessary to participate in telemedicine? Do you have a computer? Do you have a smartphone? And more importantly, do you have broadband internet? And then you might have these tools, but the other issue is, how do you use it? How can you access the software? What are the steps necessary to initiate a visit? So these are some barriers, but they should not be barriers that preclude the use of telemedicine. I was fortunate to be able to work with a group within Baltimore City, and we were interested in looking at who is accessing telemedicine. Well, we looked at 845,000 video visits in Baltimore City, and we saw that 91% of people that participated in telemedicine were non-Hispanic. We saw that 62% were white or Caucasian that participated in telemedicine, and only 23% were actually Black or African American. And as Dr. McDowell just showed us, the demographics of Baltimore, which are approximately 62% of African American and 27% of Caucasian, this is completely on its head in terms of who's participating in telemedicine. We also looked at what's the age of those people participating in telemedicine. It turns out the average age is approximately 45 years old. So we concluded that video visits were mainly assessed by white or Caucasian adults between the ages of 31 to 64. It begs the question, does this reflect our health system demographics? We can say no, based on what Dr. McDowell just showed us. And it also shows us that health inequity exists, unfortunately, in Baltimore City. We also looked at what about internet access? As I said, in order to participate in both remote patient monitoring as well as telemedicine, you need to have internet access. This is data from the ABLE Foundation, and they found that the lowest households, the households at the lowest amount of broadband internet were in West Baltimore and East Baltimore. As we went north, certainly into the county, you had much higher incidence of broadband internet availability. And then finally, I'll share with you one other study that we were able to examine. We looked at neighborhood levels of social determinants of health. Basically, what we looked at was people's income, education, employment, and housing quality, and found out that those who came from low socioeconomic background, only 6% of these patients actually participated in telemedicine. In fact, we were able to identify specific zip codes within Baltimore City that barely used telemedicine. And in other zip codes that had higher socioeconomic status significantly participated in telemedicine. So this really shows us, again, that health inequity exists as it relates to telemedicine. So that brought us to the conclusion that it's now time for a call to action. The call to action should include improved technological access. There should be improved distribution of medical equipment, as I said, for remote patient monitoring, extremely important. There should be expanded broadband internet. We just saw the data from the ABLE Foundation indicating that broadband internet is sorely missing in certain areas within Baltimore City, and it should be available as well as affordable. The distribution of cellular devices should be something that absolutely should be pursued, because we know we need these cellular devices for both remote patient monitoring as well as telemedicine. And finally, we believe that waiving medical copays for remote patient monitoring should be something that is persistent and available for all of those throughout Baltimore City and Baltimore County as well. I thank you very much for your attention.
Thank you, Dr. Williams. What a very interesting presentation. As we move forward as a city and as a nation, the use of telemedicine and remote patient monitoring will be a bigger part of the medical system. So we need to find ways to ensure that all individuals have the access they need to these technologies to be healthy. Are there any questions for Dr. Williams about her presentation? One of the questions is, what are some strategies that may help close the gap on use of telemedicine and remote patient monitoring?
So as I mentioned earlier, some of the things that will close the gap would be, for example, to be able to have available internet and broadband access to the city, and those who are in Baltimore City or any city really, as well as comfort level. There many times people require training, and so that training doesn't necessarily have to be by their medical provider. It could be from a younger family member who will set them up, for example, on the platform that's necessary to use for telemedicine. And also, making sure that letting them know that it's not terrifying to be on a computer and actually get medical advice that way. And so knowing when you need to be in front of your medical provider, as well as knowing when you can be in a distant area, but also get medical advice and be seen by telemedicine. I think all of those things, in addition to the structural issues within the insurance payments and stuff, which a patient cannot do that, but certainly those within the system, the healthcare system can.
Thank you. Any other questions?
I'm happy to, I see another question. It says, how can we make sure that insurance companies do not make city residents pay more for their co-pays than other areas of the state? Wonderful question. I will say that I was, even though I'm not a skeptical person, I was very, very floored by when I had this conversation with Dr. Ezegu, who personally, as I said, worked on working and making a resolution to reduce these co-payments. But I think what we need to do is not to have a resolution for this insurance company or that insurance company, but it has to be across the board that we're providing this coverage across the board. We either get rid of the copay completely so that everyone can participate in that.
There's another question. Am I to check with my insurance company to find providers who do remote patient monitoring and telemedicine?
Yes, I think that would be an excellent suggestion, but I would really like my colleague, Dr. Ezegu, to talk about this because he is very much in the weeds with this.
Greetings, everybody. Dr. Ezegu, pleasure to meet you all. I'm a cardiologist here in Baltimore. I'm the medical director for Just Heart Cardiovascular Group, which has offices in Baltimore City and also Baltimore County. I'm the current president of Baltimore City Medical Society and a member of the Association of Black Cardiologists. So on behalf of BCMS and ABC, I welcome all of you. But in addressing the questions, how we can, cover coverage for remote patient monitoring, it requires legislation. Thank God, at least now that in Maryland, all insurers are supposed to cover, all type of telemedicine, which remote patient monitoring is an aspect of it, but is not televisit. But there are some barriers being created by different insurers where they may even tell a patient that we're not covered for that. But I think it requires a lot of education, not only to patients, but also to providers, and also educating insurance companies on the beneficial aspect of remote patient monitoring, because overall, it actually reduces the cost of care. I think you're muted.
Are
Magadi,
there any other
yes, sir.
questions? Okay. We will now hear from our roundtable about what several organizations are currently doing in addressing cardiovascular disease and explore ways that perhaps we can do more to bridge the gaps that exist in our communities that are preventing our community members from achieving their better health. I will now turn the program over to Dr. Kamilis Ezeugwu, cardiologist from Johns Hopkins School of Medicine, who was just speaking just a few moments ago.
Again, thank you all. I have introduced myself to you and I welcome all of you. We're gonna go to our round table discussion and take some of your questions and address them. I'm gonna let my colleagues in the round table introduce themselves, and I will start with the Kelly Green. Please go ahead and introduce yourself.
Yes, good evening, everyone. I am Deborah Keller Green. I am the founder and CEO of Keller Professional Services, and I also serve as the chairperson of the Greater Baltimore Black Chamber of Commerce. And thank you for having me this evening. It's a pleasure.
Thank you. Reverend Hickman, please.
Hi, I'm Reverend Deborah Hickman. I am the founder and CEO of Sisters Together and Reaching, a 30-year-old community-based, faith-based organization that has been in Baltimore City, doing very, very well in this, in the climates that we have had to exist in to help our people move forward to the best of our ability. And to do that, I have to say that we have had phenomenal staff that have been expertly trained as community health workers, and I call them the backbone for making certain that we will be able to excel in community engagement, which is needed in order for us to bridge the gaps that we currently have in our city, in our nation, actually, to speak. But I'd like to also say I am the community co-chair at the Center for Health Equity, that Dr. Lisa Cooper is the one that actually is the director there, and she does a phenomenal job of responding to cardiovascular issues, diabetes, obesity, and the like. And I think we need more of that in our community, but I'll say more as we move forward in this conversation.
Thank you very much again. I appreciate your your introductions. We're gonna go ahead and read some questions from the question and answer, and I encourage the audience to please type in any questions you have.
Dr. Ezeugwu,
Yes.
if I can interrupt you, just also we have to introduce Reverend Nevia Brown.
Oh, I'm sorry. I'm very sorry about that. Reverend Brown, sorry. Go ahead, please.
Good evening. I'm
Yeah.
Reverend Neva Brown, and I serve as a chaplain at Morgan State University Memorial Chapel, and also as a deacon at St. Bartholomew's Episcopal Church in Baltimore City.
Thank you very much. Sorry about that oversight. Sorry about that. Then I go on with the first question we have on the chat. One, it says, what activities or initiatives has your organization been involved in around improving health of the people of Baltimore? So we'll start with Keller Green, please.
Okay. Well, first, I'll start with my role regarding as a business owner, and my business is in management consulting and human resource consulting. So I know firsthand as a business owner that that business is very stressful, and that stress is a major catalyst for poor health. So I want to speak a little bit about that, but more specifically in my role as the leader of a Chamber of Commerce, our mission is to support the growth and development of Black-owned businesses. That's our mission for the Greater Baltimore Black Chamber of Commerce. But we are keenly aware that we cannot grow business without a healthy workforce. So being invited to this forum actually has expanded my perspective. So we have focused a great deal on how we can assist our members in growing their business. And to be quite honest, I will confess that health has not been a focus until now. So I want to thank you for, bringing that to, just by saying yes and being obedient, that I can be responsible in my role as chair and incorporated in the chamber's business. However, as a business owner, I have been more responsible.
Thank you.
So I can talk about that a little more, but I want to answer your question in a long way to say that until now, it has not been a focus.
Thank you very much. Reverend Hickman.
So thank you very much, Dr. Ebru. I want to say, first and foremost, the mission of Sisters Together and Reaching is to advocate and provide optimal health and wellness to the underserved and at-risk communities in a holistic, faith-centered environment. And in so doing, we have been blessed over these 30 years to have hired well over 380 some persons from community and train them, as I stated earlier, I jumped the gun, to train them as community health workers. Community health workers who are knowledgeable about disease entities, are knowledgeable about how to document when they are door knocking and going into people's homes and assisting them with being able to have access to the resources that they need in order to help stabilize not only their health, but also their housing, and as well making certain that they have food and that they are actually being compliant and understand the necessity to be compliant to their medical appointments. We have devised programs that bring them together on a weekly basis for support groups, held lunch and learns so that doctors such as yourself and those that we have heard from earlier can come in and give them a basic overview and talk to them at their level so that they understand and they ask lots of questions. But I think one of the programs I have been most pleased with is our integrative cooking classes that we started during the pandemic, helping people to understand how to actually prepare healthy meals that are not salt laden and not saturated in gravies and things of that nature, and showing them how to use the tools in their kitchen and be able to take from our classes that we held here in person a batch of food that would be enough to feed not only a family of 6, but they could share with their neighbors that food. And it's been really phenomenal to go out into community and share, and also have those persons come in and say, why can't we take this to the streets? And people would really love it. And so those are some of the things. But I want to say our community core, our community health worker core, I think that they are prime in terms of when we talk about what can we do and what should we be doing, we should be doing community engagement at its highest. And that is because the people in community learn to trust those that look like them, listen. Listening is the core component, listening to their story, not us telling our story, but listening to their story. And I'll stop there so that Reverend Brown can jump right in here, because I'm quite certain we are of the same house.
Very good. Thank you so much. Reverend Brown, please go ahead.
Yes, we are of the same house in order to hopefully do what we do in a holistic manner. And I want to speak about what is done on the campus at Morgan State University. through the dean of the chapel, who is Reverend Bernard Keels, we started 5 years ago to incorporate with our midday meditation, which is a weekly hour where we bring students and those in the community together for a time of meditation and a time to have a nutritional meal, in partnering with the nutritional science department on Morgan's campus. So teaching both our students who are of various ages and those in the community about eating healthier meals is something that we have been doing. Now, of course, with the pandemic, that sort of took a hit in terms of being in person and having food demonstrations, which we have had, so that the individuals who come would learn how to prepare those meals and take away recipes for healthy eating. So now getting started again, we are again providing healthy meals that are provided by the food services at Morgan. So tying that into another program, because what did strike me in the statistics, we talk about those who are on the margins in our communities and the number of homeless people every night. Homeless people have some of the same health issues that are not always addressed. So in partnership with the Salvation Army, we provide a healthy meal package to those who are on the streets. So another way of a holistic approach in terms of the communities that we serve. So there are many ways. I'm sure in thinking about the homeless, we don't always have the numbers of those who have heart conditions, but they are also a community that we want to serve.
Very good.
May I just share something in terms of, I said before that, that the chamber hasn't been focused on health, but but we have had some, we look at dealing with issues of inequity across, access to capital and everything that we've talked about in terms of the disparities in our communities also, translate to those same disparities in, Black-owned businesses. So when we're looking at the health disparities, they also, in partnering with organization that looks at access to affordable housing, advocating for equity in our communities, looking at our businesses, focusing on how we could better have better employment practices and those kinds of matters. So there is a correlation.
Okay.
As we look at the inequities in how businesses could be better positioned to impact the communities if our businesses could scale, pay a decent wage, have individuals be able to afford to take care of their families, and then have a more positive impact in community health.
Thank you very much. Thank you.
Mm-hmm.
I did want to ask the group a question. So I know with the coronavirus, hospital individuals going to the hospital was kind of discouraged. And so you would have probably seen a drop off in people going that. And so you would expect that more people would have to do virtual visits if they're having visits with their doctors. I wanted to ask the panel, starting with you, Dr. Ezugbe, did you see an uptick in the number of virtual visits? And then also if anyone else on the panel, Reverend Hickman or Reverend Brown or Ms. Keller Green, do you have any experience with visiting your doctor virtually since we are in that age of COVID?
Yes, as I'll take that. And in the beginning of COVID, before COVID, of course, most patients were in office. So we started from, half and half in the beginning to where was almost 90% of our patients were by virtual visits. However, our office, we escalated, virtual activities, again, through remote monitoring as well, to really be able to take care of many of our patients. Because if you remember, people were being asked not to go to the emergency room if they're having issues because there's a lot of COVID patients. And we are dealing with a lot of cardiovascular patients that can, things that can actually can be catastrophic. So we had to really move, strongly into use of video visit, telemedicine, remote monitoring, pushing to see that everybody have access to that as much as we can. And then also making sure that they can even be able to pay for that, because the insurance was actually preventing them from getting, being paid, covering for those services. So you see patients saying they don't want to participate, but actually they need to participate because of their health care. So I'll just turn it over to the next person.
And so along with that, STAR had never been in a space where we actually worked from home, but we began to work from home, but we held huddles with our teams each day to make certain that they were reaching out to our clients, our care managers, our outreach workers, our counselors and testers, all reached out to all of the persons that we had on our list to make certain that they were okay. And what we ran up against were, we had a lot of our seniors that were being told that their next visit would be via telehealth. And so therefore, we got into the groove of making certain that our staff had appropriate PPE so that when they went to their homes, they could talk to them on the porch, but they did not go inside. They could, on a couple of occasions, it was necessary to go in to show them how to even set up their computers and get them started and moving. Alongside with that, we also went out every Thursday since the pandemic began and Hopkins began to look for agencies to work with them to distribute food. So we've been taking food to our patients since the pandemic started and since they started the program, which has now been over a year, delivering fresh produce, meats and the like directly to their doors, answering their questions. And some of the persons that have been working from other organizations with us, with Hopkins, have created recipe cards and things of that nature. So, but the big deal is right now, to the question that you asked, is about telehealth. And I think until telehealth can have equity in it, where everyone has the appropriate equipment, the appropriate training, and also if there is cost associated with it, everybody is on the same playing field. And that's up to us at this present time. I am grateful to you, Dr. Ivy, for having the Spirit of the Heart conversation tonight, because this is a much needed conversation, probably larger than the time that we have this evening.
Mm-hmm. And to your question, in terms of my own experience, I actually lived in West Baltimore, and I know that what Dr. Hickman says is absolutely true, because I know that there are individuals who did not have the technology and the know-how, but I actually had my own experience, and I consider myself very computer literate, but I did face the barrier. I think with the intensity during COVID, I think my healthcare system was not, I think that there was some unpreparedness on their end to address the immediate accelerated need to try to shift and pivot into telehealth care. And so I faced the challenge with, I had a situation, I was experiencing some of symptoms of concern, and I attempted to, reach a physician and I could not figure out how to connect. So my barrier was not that I didn't have the internet bandwidth. It was trying to get, not knowing how to work within the healthcare's technological environment. And so it, became, very frustrating, and I didn't resolve the matter in as a timely manner. It was something that, it wasn't a serious matter, fortunately. So it wasn't an emergency, fortunately. And but had it been, it wasn't a positive experience. And I am of that older generation, and I had been accustomed prior to that of going into, to see my doctor personally. So I understand. I see the pros and cons, but I think that proper training and proper time to that transition should be given.
I can speak to it from my own personal experience as well, not me personally having the health challenge, but my husband has a heart condition, which did require telemedicine, in-person visits, and we were fortunate that we were able to do some of that during COVID. But the difficulty is that my husband is not technically literate to the degree that he could do this on his own. So without my helping and doing what's needed, he would not have been able to get the kind of healthcare information using telemedicine. So that means that everyone needs to have the kind of training and access, even to the point that one of his doctors reluctantly does not use some of the technology. So that was kind of a halfway of getting his appointments through telemedicine, where some other doctors were more sophisticated in terms of the technology that was being used. So having that experience has kind of taught me to appreciate the fact that when you cannot have a personal visit, which we were accustomed to having for all of our appointments and questions or checkups, that we will have to know how to use the telemedicine, but there's still going to be limitations because I'm in that age group and my husband's not going to learn how to do these things now because he is depending upon someone else. And there are many seniors who just will not learn how to use these tools of technology, not because they probably don't have the understanding, it's just a reluctance from some, and some really cannot get it all together. So I've had my own personal experience with it. And there's a senior building that I am affiliated with where they had some of the same issues because the seniors in the building are not all technically connected. So they had to rely on family members to help them, the individuals who went to the senior building daily during COVID to work to help them through these challenges. So that's the community I think that we really have to also be concerned about. How do we help our seniors who will not always have access?
Yeah, that's a good point. And I know that, in conversations with the Center for Disease Control and other groups, there, in addition to the telemedicine where you do the visits with the doctor, there are also like self-monitoring blood pressures. You might walk into Walgreens and you see the blood pressure cuffs that allows you to check your blood pressures. There are now ways to check for diabetes and control your diabetes by finger sticks and other tools at home. Have you all seen these tools in your neighborhood? And can you think of ways that we can increase and expand, the use of blood pressure cuffs or other devices like that in our community so that individuals can be more aware of their risk of cardiovascular disease?
I would say not based on telehealth, but based on the fact that the Dr. Coopers of this world have had awesome blood pressure programs where community health workers have been trained. Our community health workers got trained through her, and how to utilize the cuff and how to teach those that are in their homes with those cuffs that signed into the program became heroes, because they learned how to trust the community health worker, how to apply their blood pressure cuff, how to actually take their blood pressure, as well as make a record of it, and also keep a diary so that when they went to their appointments, they were able to share that. But it would be nice if it was done differently over telehealth, but that would require something that I imagine or envision in my own spirit, that the money is not going to be there, or the cost is going to be astronomical for us to do the education, for us to provide the equipment and the like.
Mm-hmm. I would be remiss if I didn't mention that I am a leader at, I belong to St. John A&E Church. And I see an opportunity in the community, in our churches, to be a site for those types of medical monitoring devices. We do have a health ministry, and we actually, our health ministry does have some partnerships with Johns Hopkins University and Johns Hopkins School of Medicine, and we've had health events at church. So I think that the faith-based community and that churches are a great, provide a great opportunity to be sites for that type of technology and monitor. So wanted to share that.
Very good, very good. Sorry, I had a little technological challenge, but we're back on. There's a question on the chat, and the question says, how can we integrate cell phone into the telehealth system? Everyone, including seniors, have cell phone. I will address that, and then I'll open it up for the rest of the panel as well. So when, during the COVID, which of course, even to now, to telehealth, we found that the major challenge our seniors and the people that had the most medical condition, diabetes, hypertension, stroke, the big challenge is really the use of smartphone. Many of them don't have that. Many of them don't have emails for you to, email address to create a cloud account for them to even use to, be, and they don't do Bluetooth, so we had to push towards cellular devices, which are more expensive, but a cellular device just functions like a regular phone. If you take your pressure, it will transmit it directly to the doctor in the platform where those readings come. So we found that those were much easier for the seniors to use once you get them set up. Once they take the pressures, even when they call you and they say they're having problems, you have them to check their pressure, check their sugar, they can do it, and they will come to the platform immediately and you see it and see what's going on. Then we pushed to develop apps that can actually call a patient in their home, and they can put their reading in their phone, even if it's a landline. And then that will be transmitted to us to use in managing the patient. We ended up actually developing such apps for seniors, English-speaking seniors, Russian-speaking, patients, and because many of the other apps wouldn't do that, and even for Spanish patients. So we can actually get readings from them directly from home. They can have a blood pressure machine or a diabetic check-in, machine, check it or their weight. And then when they get the call, they can enter the information on the phone and they come directly to the doctor. So that's actually a very, very good thing that can be used in many communities because everybody have a phone. Yes.
I think, Dr. Igwe, everybody has a phone, but not all phones are equal.
That's true.
The majority of
that is so.
The majority of the phones that our seniors have, and I'm a senior. I say our seniors have, but I'm a senior, so I have to, say okay. But I have a smartphone, but I don't say that I'm all that smart. Samsung offers me the ability to take my blood pressure on there. I had to learn how to do it. Yes. However, but I would say, in order for our seniors that have government phones, they would have to have a greater capacity of time placed on those phones because they have a limited amount of time. And so the governments need to understand that they can do a great service if they would allow them to have those accesses to do that.
And that's really the truth. That is very important because the limitation in terms of the time or the credit on their phone can actually limit even they are calling you for telemedicine and how much they want to spend to tell you, what's going on, and even inputting in data. So those basic things should be addressed. Yes.
Yes.
And one of the other challenges that I also find, as you said, Dr. Igwe, to have that information transmitted to your primary care physician, your cardiologist, is that participating in the network of doctors to receive that information. As I said, there's a reluctance on one of the doctors that we have in our care network who really is not willing to do all of the technical advanced things that could improve. So again, there are some limitations on both sides in terms of a challenge to make sure we can provide all of that.
You are absolutely correct. And as we all know, this remote patient monitoring activity requires not only education of patients, but also educating the providers because there's a lot of barriers. Some of them are afraid of it. So it requires work, both from the patient side and also from the physician side. And there have many organizations that are trying to take the work out of the doctor's office so that they'll be the one collecting the data. However, the doctors still have to review those data and be able to manage the patient and have a team. And we are willing to work with any team in Baltimore to really show them how to do this because our patients need this and we have to do it.
Yeah, I do have one question that came in and it was churches and faith-based institutions face similar challenges with elderly members and virtual church attendance. Youth ministries, though, have partnered up with seniors to help with these technologies. So would this model also work with telehealth, maybe getting the youth ministries involved?
I think yes.
I think that's
However, I would say that there's a safety factor in all of this that we have not discussed tonight, because you do have a lot of hackers and you also have seniors that are very reluctant to use any kind of IT because of these issues that are taking place. So I think that the answer is yes, that would help, because that's a beautiful thing for every congregation to have their youth engaged in working with the seniors. And also it gives seniors company, someone to talk to, someone that cares, and it helps it keeps us moving. And so I would say yes to that, but I would say also, let's make sure that we think of safety factors.
Yes, I agree. It is a great idea, and I would like to add in terms of I am here representing businesses, so there are additional things that businesses could also do to help incorporate a more health into the business culture. So I would not want to overlook that factor that we as business owners and employers, there's some very simple or uncomplicated some enhancements that we could incorporate to, again, be more health conscious, or make health more part of our culture, in terms of incorporating it in our training curriculums, and in terms of incorporating it in our onboarding systems, just knowing more about our employees' pre-existing health conditions. After they're hired and they come on board, you need to, that, we always collect information about emergency contact. Why not, have a fact sheet on any pre-existing condition, so that we're knowledgeable and aware, and just small things like that. And as we do that, we could also include wellness in our benefit package. So the businesses could also become part of this whole wellness component, and also incorporate what we're talking about in terms of needs in the community, because some of these businesses are probably in the community. So
that's excellent.
So I just wanted to kind of not overlook the business role in the matter.
Yes, and I couldn't agree with you more that it's going to take a whole community approach. Businesses, churches, community-based organizations, as well as working with the healthcare system, with Johns Hopkins and with University of Maryland. How do we create that environment that helps everyone have better access to care? So moving on in that theme, because, really looking at what our call to action could be, I wanted to go next to the community-based organizations. And I know that wonderful work has been done by Sisters Together, Reaching. Could you give us a little bit more about maybe, over the next 6 months or a year, steps that could potentially be taken with the community-based organizations to improve care?
I think that what needs to be undertaken for community-based organizations in the midst of the climate, the COVID climate that we are still in, that we would actually need to make certain that we are getting funded. And those are things that oftentimes elude us or shut us down, because we don't have the same capacities as Corporate 500 or other businesses, and especially Black entities. People want to tell us what to do, and when we go out and we do it, and we do a great job at it, and they learn from it, they want to then take that and publicize it for themselves and bring in their own, but then they find out that they can't do the same work the way that we have done the work. Then they look back and want to come back, but we need consistent, sustainable funding to be able to move forward. And I would like to believe that over the next 6 months that we would continue to grow our entity as we have over these last 30 years, to continue to train persons in community. We need good soil and we need great seeds. The soil and the seeds are in our community, and we have to actually give them the listening ears, and we need to give them the capacity to know that the job you're looking for is right here, helping your next door neighbor, or helping the people that are 3 blocks away that are familiar with you, will allow you into their homes to help them set up their laptops and set up telehealth and those types of things, if that's the way we're going to go. But I think that all of our entities need to take on making certain that we are resource rich, and making sure that we can get and secure adequate housing for our community members, as well as good food for them, a place where they can get fresh food. And the food that they have been cooking here at Star is fresh from Giants, delivered on the day that we're doing these services, making certain that we can continue to do the lunch and learns, check in on our people, do the assessments, and really feed that information back to the likes of the Association of Black Cardiologists to say, these are the things that need to be done. We need to stay in steadfast communication of where we're lacking, what we do and how we do it, and how we can each help each other.
Absolutely.
And then Reverend Brown, do you have any thoughts on what the health ministries and the churches how they can get involved to work.
For the churches, and especially where I am serving, we do have a food pantry where we work with the Maryland Food Bank in order to provide healthy food and foods that are needed in the community several days a week. But I'm thinking now more in the education as to what I can now take back to the church and talk to them about in terms of presentation, blood pressure screenings, the things that we have not been able to do. And we have been open even during the pandemic, but we're so limited with that actual physical touch because we were able to do blood pressure screenings when we were in person during and outside of church services. So now without that actual physical touch, in a number of times, we're not able to do that, even though we might be in person. And I'm thinking through the ministry at the chapel at Morgan, we can also find ways to expand what we're doing once we're able to have more in person and bring in individuals from the organization, from the business community, from the healthcare community, to talk to our students and the community members more about understanding your heart health.
Wonderful.
Can I say one more thing, Dr. Ivy, and that was, I forgot to say, we also have a almost a 40-foot mobile unit that goes into communities. So we go wherever, we do mapping and we map the communities that are in need and we go there and offer them services. We do HIV and Hep C counseling and testing, as well as that we have student nurses that are interning with us for like 3 or 4 months. And they are out there on the mobile units doing blood pressure screens. We have we're training our community health workers in mental health first aid. So they do all of those things when they go out into community, they're able to ask, to provide the necessary services. And so having doctors come on, like doctors from Greater Good have been out to do feed check for diabetes and things of that nature. And so all those things are necessary in our community. And I think that is the way of the future.
Mm-hmm. Can I just say that I want to commend, the great work that we do in our communities in terms of nonprofit organization and faith-based organizations. And we are underfunded and under-resourced. And one of the initiatives that the Chamber is involved in is Community Reinvestment Act of Baltimore. And that basically is a initiative that looks at providing equity in banking for 4 different areas. One is in business, business development or access for businesses in Black and Brown communities, nonprofit organizations, and affordable housing, and community development, development along the lines of businesses that provide development in communities. So I know that, as a nonprofit and faith-based organizations, we do rely a lot on fundraising, but we should also have the same access to capital as other businesses. So I will, that is a initiative that I think touches all aspects of our community, and I'd be glad to, to make sure that we're sharing that information and the data, because we are meeting with top banks in Baltimore who collect a lot of deposits, but they're not reinvesting in our community. So we are holding these communities accountable.
Wonderful. And I know we're getting low on time, but I wanted to just give one more question to Dr. Ezeugwu. What are some of the ways that the healthcare system itself can help? You've heard from the CBO group, the minister, and then the business group. you have some ideas about how Johns Hopkins and other health centers can get involved.
Yeah, definitely. Many of the patients in our community that need the most care don't have, the internet accesses, and we can actually, help by at least seeing ways to get those broadbands in those locations, either through government funding or sending some of our students to work with, people in those areas. And also to be sure to let people know that, you can transmit the readings securely with no interference on your, on your personal information, per se, to your doctor to use. So there are ways we can utilize students, because remote monitoring is going to become the future. So we're going to be training students, and we can send them in communities to help in those, even in churches. So grassroots way of educating our patients, because through remote monitoring, they actually learn how to leverage what they are, whether the food or what is causing their pressure to go up, their sugar to go up, and somebody can, work with them directly in that way. So institutions can actually go down to the community in this situation, partnering with churches. Yes.
Wonderful, wonderful. So we're running out of time, so I just wanted to give a quick wrap up. Thank you so much to our roundtable participants for participating in our event tonight. You are the ones that made this a success. So thank you so much. Just to give a quick wrap up to everyone about what we discussed tonight. We saw from the Dr. McDowell that cardiovascular disease is a serious issue in Baltimore, and we need to take steps to address it. And we realized with this coronavirus situation that has occurred, but even outside of that there are health disparities that are really plaguing our community. But there are solutions, and looking at the strategies that we talked about tonight in terms of using remote patient monitoring, in terms of engaging the community-based organizations, Sisters Together Reaching, along with the faith-based community, the church ministries, and the business community as well. We have to figure out how do we move forward with implementing these strategies in our community so that we can begin to close the gap on health disparities. I do realize that we're over time, and I want to thank everyone that was able to attend tonight and work with us on this. We know that it's going to be an ongoing situation that we have to work on. This isn't something we can turn our back on, because as we saw from a lot of the information provided, that our communities are the ones that are suffering because we lack the access to this. So engaging our communities to figure out how we improve care is all of our mission. I would like to thank everyone, and please have a nice night.
Thank you.
Thank you. Thank you.
Thank you very much.
Thank you. Good night.
Thank you so much for your participation.